Welcome to this lecture on cardiac PET studies. This lecture will cover cardiac viability, cardiac amyloidosis, and cardiac sarcoidosis imaging. These are the objectives for this lecture. First, we'll start with cardiac viability. Arteriosclerosis is the most common cause of death in the United States. This leads to cardiac dysfunction by interrupting the delivery of oxygen to the muscle. This can cause myocardial infarction or arrhythmias. With coronary artery atherosclerosis, in some patients, the plaque formation is gradual, which leads to collateral blood vessel formation. However, in some patients, a single larger plaque in a strategic location could prove fatal. If coronary artery insufficiency does occur, the end result could be arrhythmias or infarction. One symptom of coronary insufficiency is angina pectoris, which becomes worrisome when the patient begins having unstable angina or chest pain at rest. There are a few treatments for coronary artery atherosclerosis. First, angioplasty, in which a catheter and a balloon on the tip is inserted to the area of narrowing. Then it is inflated, compressing the plaque out of the way. A stent can be placed to maintain the patency. Alternatively, some patients may need coronary artery bypass grafting or CABG. This is an open heart surgery that uses segments of other veins to bypass the blockages. Atherosclerosis of the coronary arteries presents in many forms, all leading to myocardial ischemia. With myocardial ischemia, it is important to remember the patho and pathophysiology for all of cardiac imaging. With myocardial ischemia, there is a decrease in blood flow to the cardiac muscle that leads to decreased oxygen supply. This leads to a damaged heart muscle, reduced ability of the heart to function efficiently, and may cause arrhythmias or may lead to infarction or other serious disease. Myocardial ischemia may result from a slow narrowing of the arteries or a sudden occlusion. The extent of the ischemia depends on the anatomic location, the extent of the occlusion, the presence or changes in other diseases like hyperthyroidism, hypertension, or diabetes, and the extent of arteriosclerosis in coronary arteries, as well as the speed at which the ischemia develops. A major cause of myocardial ischemia is arteriosclerosis, or that plaque buildup in the coronary arteries. Could also have a non-occlusive or an occlusive thrombus. With clinical presentation, about 10 to 25% occlusion will be asymptomatic, or the patient may have mild angina with exercise. A 50 to 70% occlusion will result typically in angina or congestive heart failure. In 70 to 100% blockage will often present as congestive heart failure or an infarction. With myocardial infarction, patients can present with chest pain that radiates to the left shoulder, arm, jaw, or neck. Keep in mind that women will often present with atypical symptoms such as nausea, pain in the neck, shoulder, or back. It can also be diagnosed with electrocardiography or like EKG and laboratory exams such as cardiac enzymes. So what happens during a myocardial infarction? The mechanisms of cell death and ischemia and reperfusion include dysfunctional ion transport. The mitochondria will fail to produce ATP, which is what the cell needs for energy and to be able to carry out its functions. The cells will swell at the cytoplasm, and then eventually the cells will burst and the cytoplasm and cell contents will spill into the extracellular space. The effects that are exuberated by the plasma membrane damage. Cardiac enzymes such as troponin T and troponin 1 and creatine kinase or CPK will be introduced into the extracellular space. So these are enzymes that normally exist within the cytoplasmic contents of myocardial cells, and their elevated levels in the blood are the result of cell death. So they typically reside within the cytoplasm. As those cells eventually swell and burst and all the cytoplasmic contents spill into the extracellular space, these cardiac enzymes go along with them. Eventually, they make their way into the bloodstream. So the levels in the blood will be elevated about 12 to 26 hours after the cell death or the myocardial infarction occurs, and then they will remain present in the blood for up to 2 weeks. The reason they remain in the blood for up to 2 weeks and they will periodically rise a little bit, partially is because it takes a little while for the kidneys to clear that out of the bloodstream. It takes a little while for them to make their way into the bloodstream, for those levels to reach a peak, and for the kidneys to begin filtering them out. Additionally, patients may still be experiencing cell death. Myocardial infarction may not just be a 1 second or one-time event where the cells burst and that's the end of it. More cells can continue to die if the myocardial infarction and the underlying causes are not addressed in a timely manner. Then more cell death will occur, and so those levels may rise in the bloodstream and be present for up to 2 weeks. The cardiac enzymes should be tested in the blood as soon as the injury is known and then repeated every 4 to 9 hours later. This is the example of that injury repair mechanism within the myocardium. And this is showing you the normal cell undergoing oxidative stress and the free radicals that damage all the cell components, and then eventually severe oxidative stress will lead to cell death and apoptosis or necrosis. And then this is diagram over here to the right is showing you that mechanism with the stress that occurs in overload, and how there are a couple different pathways that can lead to cell damage or cell necrosis. And this is showing you the course of inflammation, injury, and repair within the myocardium. So when there is an occlusion that occurs, the cardiac onchosis and apoptosis will present along with inflammation. And then this is one of the reasons the cardiac enzymes may continue to rise for up to 2 weeks or be present in the blood for up to 2 weeks, because there will be a border zone of damage with more apoptosis that occurs. And as that cardiac apoptosis and even border zone around where the initial injury occurred, there's a granulation of tissue, fibrosis, and angiogenesis. So new blood vessels will form, tissue becomes granulated, and scar tissue starts to form. That's during the tissue repair phase. As there is that border zone apoptosis, more cells may continue to die in that 24-hour to 7-day period, and the cardiac enzymes may continue to rise in the blood. Granulation and inflammatory cell apoptosis will occur within that first week as well. And those inflammatory cells will start to die off and lose their purpose. And then after 7 days, there's scar tissue that starts to form. You have compensatory dilation and remodeling that occurs within the myocardium. This is another diagram showing you the mechanism of infarction and how that inflammatory cells will rush to the area, And then you have the anti-inflammatory cytokines, pro-fibrotic signaling factors, and eventually the scar tissue will start to harden and form. So I is the infarct zone, B is the border, and then R is remote areas. But as you can see, this is the normal pathway of inflammation, injury, and repair within our bodies. It's a little bit different in the myocardium because just because it's the myocardium and your heart is continuing to work and need to function. So there's a lot of disruption that can occur there, but initially the inflammatory cytokines will rush to the area, followed by the anti-inflammatory cytokines and the fibrotic signaling factors. Those eventually will attract the collagen and things like that that help form that scar tissue and stiffness that will occur. There are quite a few complications that can happen with myocardial infarctions. First is ventricular rupture. This is where the weakened myocardium may rupture. Blood will fill the pericardial sac and compresses the heart. This is a life-threatening condition. Cardiac tamponade, the compression of the heart by blood in the pericardial activity or pericardial cavity. This can occur about 5 to 7 days after the myocardial infarction, and this is usually but not always lethal. Ventricular aneurysm. This is due to a massive infarction and scarring that occurs where the ventricular myocardium will actually kind of bubble out, just like a normal aneurysm, but it's occurring in the myocardium and the ventricles. Endocardial neurothrombus. The endocardium overlaying the infarction is disrupted and causes blood to coagulate. This can become an emboli, and this can contribute to congestive heart failure. Also, when that becomes an emboli, it can travel to other areas as an embolus. So there are two things that can occur or happen after myocardial infarction: hibernation and stunning, which is what brings us to the viability study. Hibernation refers to the adaptive reduction of myocardial contractile function in response to reduction of myocardial blood flow. And stunning is the prolonged and fully reversible dysfunction of the ischemic heart that persists despite the normalization of blood flow. So what we're looking for with viability study is hibernation or stunning. So both of those could be reversed if they're caught in time before more infarction and cell death occurs. So this is the methodology for myocardial viability studies. The viable myocardium may be stunned or hibernating. Glucose metabolism is critical process for cardiomyocytes to generate energy. During myocardial ischemia, the energy supply the cardiomyocytes is reduced, leading to impaired function. And then as a result of ischemia and hypoxia, cardiomyocytes switch to anaerobic oxidation of glucose to produce the ATP. So the cells stop taking up the fatty acids and start taking up glucose instead. And it's a way of them having that quick, fast energy fix. Think of, just our bodies in general. If you need a quick energy boost, sometimes it's easier to go for something that has sugar rather than going for something that has proteins and fats. And it's the same thing. Our myocardium does the same thing. When it's injured and it's struggling to get what it needs and it's hypoxic, then it switches to a quick energy supply, a quick and easy fix, which is that glucose. So glucose uptake is upregulated in stunned or hibernating myocardium, and intervention has to occur to avoid further cell death. So some of the patient history that's really important to take for a viability, asking the patient if they're diabetic, pre-diabetic, or prone to hypoglycemia. and knowing if they're insulin resistant. Knowing their body's kind of normal reaction to glucose and how much glucose may be in their bloodstream is important, especially when we're giving them glucose and we may glucose load them. It's really important to know where they're at and take a blood glucose level. Medication history and allergies are important to assess, as well as symptoms, cardiac risk factors such as smoking, obesity, previous cardiac history, if they have a known history of MI, EKG changes, CABG, stenting, or angioplasty, diagnostic and therapeutic history, such as coronary or CTAs, calcium scoring, or MPI studies, and then results of recent nuclear medicine studies, especially MPI SPECT or PET CT imaging. The radiopharmaceutical for viability studies with PET is FDG. The indication is to determine usefulness of revascularization in patients with matched defects on perfusion images. So what you're actually trying to look at with the viability study is if that myocardium is still viable, if it's capable of surviving, if it gets revascularization. These patients will often look like they have a fixed defect on rest and stress images when the myocardium may actually be able to be revascularized, and it's just a result of hibernation or stunning within the myocardium. It is essentially important for those patients to get evaluated in a timely manner and identified, and get the revascularization completed before more cell death occurs. Patient prep, the patient should be NPO for 6 hours. It is important to check the blood glucose levels before injection, and glucose loading can be done per protocol. Some places don't do it, some places do, some places use oral, some places use IV glucose, and it may also, some places may administer insulin. There's a few different protocols for glucose loading if a facility decides to do it. One key important factor, though, is that it's always performed under the direct supervision of a physician. Inject when the optimal blood glucose is achieved, and then scan the patient at least 45 minutes after injection. Patient will be supine with their arms up, and they will be imaged for about 20 to 30-minute acquisition. The actual acquisition time will vary a little bit per protocol and per scanner, sensitivity, efficiency, all of that. And then the images will be processed and compared to a resting perfusion study. So if the blood glucose is greater than 250 milligrams per deciliter, it's important to contact the physician. The patient may not be able to be done that day. Some may administer a little bit of insulin. If the blood glucose is less than 250, then you can administer 25 to 100 grams of oral glucose per protocol, and then check the blood glucose levels every 5 to 10 minutes. It is very common for facilities who are doing viability studies to have a nurse constantly monitoring the patient with their blood glucose levels. Glucose must be loaded before the FDG injection, and then the patient will need monitored throughout. If the if pharmaceutical is added for stress imaging, then you also want to avoid caffeine or interfering medications. In some patients, a full MPI study is acquired before the FDG is injected, but that is again per protocol. Just know that if you're doing an MPI study, pharmaceutical study, especially if it's a PET CT MPI study, then the patient should be withheld from caffeine and any interfering medications. So these are the radiopharmaceuticals and pharmaceuticals that are used. F18 FDG Typical dose is 5 millicuries, but the range could be 15 or 5 to 15 millicuries. And then the administration is given IV. Glucose is 25 to 100 grams. You want to maintain a blood glucose level of about 100 to 140. And this is done with the oral administration of glucose. That's the most common way. Some patients may be given insulin. This could be IV as needed. And if insulin is used, it's about 1 to 5 units. And then 45 to 60 minutes after the glucose loading. Insulin may be supplemented to maintain that ideal blood glucose level. It is ideal for the glucose to be between 100 and 140 milligrams per deciliter. Using this table kind of adjusts for how much insulin you would give. And if their blood glucose goes above 200, you may want to notify the physician. It is essential to wait at least 45 minutes after the FDG injection before imaging the patient. For patients who are diabetic or have a high blood glucose level, it is essential to wait about 90 minutes post-injection. That will allow for better blood pool clearance and better uptake into the myocardium. This can affect the overall count rate if patients who are diabetic are scanned too quickly after injection. Place the patient supine on the table. You want to position their arms above the head if able. You want them to be out of the field of view. If they're unable to bring their arms above their head, you can keep them down, but you may want to increase the transmission scan time if you're doing standalone PET, and keep the arms in the same position for transmission and perfusion scans. So the acquisition parameters will be slightly different whether you're doing PET or PET-CT. The main thing there is the attenuation correction. If you're just have a standalone PET, you need to do the transmission scan. If you're using PET-CT, which is preferred, the CT scan will be used for attenuation correction. And then also for the resting MPI study that goes along with it, you can use either N13 ammonia or rubidium 82. If you're doing, or regardless of whether you're doing N13 or ammonia, both of those will be a bolus injection. It's best to get the myocardial blood flow reserve with it, so you want to capture that as a flow for the resting study. For the F18 FDG, you want to make sure that you're injecting it slowly. That should be slowly injected over 1 to 2 minutes. Do not bolus the FDG. And then injection to imaging time, if it's ammonia, it's about 1.5 to 3 minutes. And then if it's rubidium 82, it's about 90 to 130 seconds. And the FDG study is about 45 to 60 minutes after injection. And remember, if they're diabetic, you want to expand that a little bit. So over to the image duration. Now remember, the nitrogen 13 ammonia, it's not both, it's either or, whichever one you're using. But the imaging time for ammonia is about 10 to 15 minutes, whereas for rubidium, it's 3 to 10. And the F18, it's FDG study, it's 10 to 30. Acquisition mode could be 2D or 3D. Remember that if you're doing it in 2D mode, that's when you have the longer time position, or longer imaging times, because you'll have less counts. And then if whether there's a question whether or not to gate, you typically don't for the viability study, but you do for the perfusion studies. And again, with the injection to imaging times, it is best to do myocardial blood flow reserve with it. These times that are given, or if you're not doing that and you're just scanning the patient, you want to give it time to localize in the myocardium. Here's that same information in a nice little chart for you. I do want to point out that the number of beds, it is just one bed position. You're just doing it over the heart. That's pretty standard. The acquisition mode could be static or list mode dynamic, and that depends on whether or not you're doing the myocardial blood flow reserve with it or not. If you are, you want to do that in list mode as a dynamic study to capture that flow for the resting, especially if you're doing a full stress test before the viability. And then when you reconstruct it, it should be iterative reconstruction. Typically, that's an OSEM, and the reconstruction pixel size is preferred with 2 to 3 millimeters. You can use slightly wider slices or thicker slices at 4 to 5 millimeters as well. When you're processing them, the image processing will differ slightly depending on the camera manufacturer that you're using and the preferences of the interpreting physician. But it will include pre-processing, attenuation correction, reconstruction, and filter selection. You always want to make sure that your cardiac PET data is used appropriately and aligned appropriately with the CT data. Sometimes it will appear aligned on the acquisition, but when you transfer it to the cardiac processing software, it may create a misalignment. So you want to check it again and just make sure that the myocardium is aligned on CT and PET. And then you also want to align the perfusion and viability slices on the processed images. So you want to match the same sections of the myocardium with the resting study as well as the viability study. Reconstruct the images by the axial views or the axis views. Short axis slices will be displayed from apex to base. Vertical long axis, apex should point to the left of the image, and the horizontal long axis, the apex should point up towards the top. So you want to make sure that they're oriented correctly. Normalize the images to the hottest pixel in each slice, and most processing softwares will do that automatically. And then display the images in quantification content, such as the polar map, and compare with any recent SPECT or MPI studies. This is just a comparison of the reliability of PET versus SPECT. I wanted to point that out to you guys because it is preferred if you are doing a viability study to do FDG over thallium, and it is also preferred to do the PET resting study over a SPECT when you're comparing it for viability purposes. And this is showing you why in these images here. A is a 70-year-old male after a CABG procedure, no history of MI, diagnosed clinically with a posterior basal MI. And you can see that it is showing up on the PET images, but the SPECT images are masking it. With B, 53-year-old male with exertional left arm pain, diagnosis with 90% circumflex stenosis. You can see slight defects here on the SPECT images, but you can really see it on the PET much, much clearer. And then with C, this is a 46-year-old female with chest pain. Diagnosis was reversible ischemia in the inferior lateral wall. And if you look at that, the SPECT data has a loop of bowel that's interfering with our ability to see that. And so that interfered with the diagnostic ability of the SPECT study on that one. For that, PET was much clearer image where you can actually kind of see that there. And you can see it down here, inferior lateral wall. D is a 59-year-old female patient with chest pain. Diagnosis was reversible inferior septal perfusion, which you can see right here on the PET stress images, but you do not see them on the SPECT images. So the image quality is much better. The diagnostic reliability is much better with PET than SPECT. And so if you're looking for whether or not there is viable tissue, it is better to get the PET MPI study with it so that you get a much more accurate comparison. Now, one of the reasons that the PET images just have a lot better image quality is just the overall physics of PET imaging and how we're getting the two 511 KEVs, the coincidence imaging. The spatial resolution is much better with PET because the technology is a little bit more improved. You also have um, better spatial resolution with the PET radionuclides than you do with technetium. So this is an example of the image findings that we see, the spectrum of disease by PET-CT to evaluate rest perfusion in metabolism. Metabolism is the FDG part, that is the viability portion. So if you see here, if the perfusion on images look normal, if there is a negative FDG study, none of that FDG really went to the myocardium, that is considered normal. That's a negative study. If the perfusion images look normal and then there's diffuse nonspecific uptake in the myocardium by the FDG, that is nonspecific uptake. This is likely failure to suppress the FDG uptake by the normal myocardium, and so this patient may not have been glucose loaded properly. And then abnormal metabolism, if there is a normal perfusion study, but focal increase in the myocardium with the FDG, that indicates early disease. There is some reversibility there. If it is abnormal on the perfusion, but then there's a mismatch pattern, which means the part that is showing up as non-perfusing on the resting study takes up the FDG, that shows us that that's a mismatch pattern and there's a focal increase. So there is some disease there and there is some viability of that tissue. If there's abnormal perfusion and or abnormal metabolism, this typically means that it's scar or inflammation and that it's not reversible. It's not going to benefit from revascularization. Some other considerations and instructions include the FDG viability study, often compared with SPECT or PET perfusion and displayed in a SLICE report. If the patient has not had a recent perfusion study, consider doing at least a resting MPI with the viability images. This is pretty common for the protocol. Also with glucose loading, you want to make sure that the technologists and or nursing staff have special training and instruction for the glucose loading protocols as well as the importance of it. And the glucose loading should always be performed under the direct supervision of a physician. You want to properly align the perfusion and transmission images to avoid any serious artifacts. If you have misaligned data between the perfusion and the viability, or the, perfusion and the CT images, then that will create perfusion artifacts on the images. So this is an example again of how the results are interpreted, and this is using nitrogen ammonia as the perfusion and FDG for the metabolism. So in the top image, you see normal or stunned myocardium, and it's not necessarily no real mismatch there. With the mismatch defect that indicates infarcted and scarring tissue, you see that there's a, match defect. So you see right here in the apex, those defects are matching. The third one here is a perfusion metabolism mismatch, and this is what occurs when there is hibernating viable myocardium. You'll see that the area over here on the lateral wall is is not perfused, but when you see the viability, that's taking up the bulk of the glucose, and that's because the metabolism in those cells that are hibernating has shifted to anaerobic glucose metabolism rather than the fatty acids. So that's an indication that this patient would benefit from revascularization. And then a reverse mismatch is seen here where the perfusion is there, but it's not necessarily taking up glucose. That's not a bad thing. It's a good thing when it's not taking up glucose. That means it's metabolizing the fatty acids. This study is a MPI PET CT study using rubidium 82 followed by FDG. And this is a case of a matched defect. If you can see, look at the anterior septal wall and even the septum, there is markedly decreased perfusion that matches on both stress and rest. And then when you look at the FDG study, that area is not taking up glucose. So therefore, you can see even in the um, even in this view, you see that it's missing the apex. And then again, in the horizontal long, you see that it's missing the apex and some of the septum. And if you look at the FDG studies, it's matching there as well. So this is an example of a matched defect, which means there is no hibernation that's occurring. That myocardium is scar tissue. This patient did not have a stress portion of the study with it. They just had a resting MPI study followed by the viability, which is the most common protocol. And this is an example of a matched defect. This is showing the quantitative data that you can see. Basically, the viability kind of replaces the stress portion, but it looks at the extent of scarring in the rest versus the viability. It will produce some stress scores. It will produce extent of scarring. And this one is showing 40% scarring. So if you can see there, there is a match defect in same area in the anterior septal wall. Now this is a case of mismatched. If you look at the rubidium rest followed by the FDG, you'll see that there is marked decrease of the perfusion in the anterior and really the lateral wall. As it progresses, you see that it's more in the lateral wall that it's missing. As you look at the vertical long axis, you see that there's areas of the apex that are missing and anterior. And then if you look at the horizontal long axis, you see anterior and lateral wall that's missing. But if you look at the FDG study, those areas are taking up FDG. They are FDG avid, which means those cells are in hibernation. They have switched to anaerobic metabolism and they are now taking up glucose instead of the potassium or the fatty acids that myocytes normally like. And so this is a good case to show a mismatch that actually shows there is hibernating myocardium. This patient would benefit from revascularization. So doing a heart cath where a stent or bypass is done would benefit this patient greatly to reperfuse the area of the myocardium that is taking up glucose and hopefully reperfuse and revitalize those areas before they turn into eventually to scar tissue. For all CT fusion images, serious artifacts can be caused if the CT and emission images are not properly aligned. So I briefly mentioned this earlier. You always want to check the ACQC or the attenuation correction quality control screen on your scanner. Depending on the manufacturer, it may be called something different, but it's the screen where you're able to look at the alignment in the images, and then you can adjust that if needed. Typically, you need to adjust it on the scanner before you send it to your processing software, which means you may need to delete it from the processing software, reprocess it, correct the misalignment, and then send it back manually to the processing station. And sometimes that will resolve it. It should resolve it, but you always want to check for that. If you see in this top left-hand picture here, where it's not following where the heart anatomy is on CT, it's misaligned, placing that the nuclear medicine images outside of the heart. What happens when that gets reconstructed and the attenuation correction from the CT gets applied is that it's kind of saying that this is the border of the anatomy. And so what it does is it creates a perfusion defect in that area. So if you're ever not sure if that's what's causing it, you can look at the non-attenuated correction PET images to see if the defect is still there. And you should always review this ACQC page to see if that alignment issue is occurring. This is showing you the patient radiation dosimetry for cardiac PET versus SPECT. And this is one of the reasons it's really good to use Viability with PET versus thallium. The radiation dose to the patient is significantly lower. And also when you're using the tech resting study followed by thallium, the radiation dose to the patient is much higher. Even when you're using CT for attenuation mapping with rubidium and FDG, it's still a lot lower. So that's a great benefit of using cardiac PET viability. So now we'll shift gears a little bit and start talking about cardiac amyloidosis. Cardiac amyloidosis occurs when abnormal proteins called amyloid fibrils build up in the heart muscle and surrounding tissues. The buildup can cause damage to the heart and impair its ability to function normally, and this leads to heart failure symptoms and reduced life expectancy. The accumulation of amyloid plaque, I do want to point out, is kind of a precursor of organ failure. Wherever amyloid plaque accumulates, organ failure follows. So when it accumulates in the heart, patients will end up developing heart failure. When it accumulates in the brain, patients end up developing Alzheimer's disease. When it develops in your joints, then patients end up needing to get like a knee replacement or hip replacement. When it accumulates in your kidneys, it eventually leads to renal failure. So this is a common theme. Amyloid plaque is just a buildup from where there's constant damage and repair, and it builds up, it accumulates in the area, it forms more scarred tissue and sclerotic tissue, and then it impairs that function, that organ or body part's ability to function normally. So when that happens in the heart, it will lead to heart failure. That does greatly impact the patient's life expectancy. There is a very strong positive predictor of heart failure with patients who have cardiac amyloidosis, and it can only be diagnosed using nuclear medicine imaging or a cardiac biopsy. The cardiac biopsy are very high risk procedures, and so the ability to diagnose that with imaging is much better for the patient. So cardiac amyloidosis can be inherited. It is the disease such as a type of bone and blood cancer, another medical problem causing inflammation, or it's also more common in men than in women. So this is an example here in the image of a normal heart versus one that has accumulation of amyloid plaque within the myocardium. That amyloid plaque kind of leads to hardening and scarring in there, and it greatly disrupts the function of the myocardium. This is in another diagram showing the effects of it and the electrophysiologic manifestations of cardiac amyloidosis. Patients will often get AFib, high degree AV blocks, ventricular arrhythmias, dysyncrasy, or end up having device issues where they need device management of their arrhythmias, such as needing pacemakers and things like that. So the need for a pacemaker, implantable cardioverter, defibrillator, cardiac resynchronization therapy, that's very common in people with amyloidosis. Another complication is developing a left arterial thrombus. Left or right bundle branch blocks are also common, as is sinus node dysfunction and AV nodal disease. And this diagram is showing you the different manifestations with the two types of amyloidosis. So there are two types, ATTR amyloidosis and AL amyloidosis. And it's showing you the origins there at the beginning. In the middle, it's showing you the presentation of them. So ATTR amyloidosis is the one that is more closely associated with cardiac amyloidosis. People will get left ventricular hypertrophy, atrial fibrillation, and atrial flutter. But the people with AL amyloidosis are the ones that tend to get more problems with their nervous system, the GI tract, their kidneys. And there are a couple red flag signs and symptoms for cardiac imaging. AL amyloidosis tends to be a medical emergency, but the ATTR amyloidosis can be treated with gene silencers and protein stabilizers. And then there are some emerging therapies for that as well. So patient management still is kind of a complex thing for patients with amyloidosis. There's not a lot of effective treatment plans or treatment options for them to slow down the accumulation or the impacts of the amyloidosis. So there is a differentiation between ATTR from light chain amyloidosis. So that's a great indication for the cardiac amyloidosis imaging. Evaluation of patients with heart failure and increased left ventricular thickness, not due to other noticeable or common reasons. African American patients who are greater than 60 years old with heart failure and left ventricular thickness greater than 12 millimeters. Patients that are greater than 60 years old with unexplained heart failure and preserved ejection fraction. And evaluation of patients with signs of heart failure in the presence of unexplained neuropathy, bilateral carpal tunnel syndrome, or arterial arrhythmias without the typical risk factors. Also, evaluation of patients with known or suspected family history of amyloidosis because there is a genetic component. Assessment for ATTR type cardiac amyloidosis in patients with cardiac MRI or echo. Results that were consistent with amyloidosis. And so some of the contraindications to cardiac MRI, might be the presence of any magnetic or metal implants within the patient. So that's one of the major contraindications for cardiac MRI. So if the patient can't get a cardiac MRI, then of course the PET cardiac amyloidosis study would be indicated. Some contraindications, there are no absolute contraindications. Pregnancy and breastfeeding are relative contraindications. Of course, that would need carefully discussed with the patient, and the benefits would need to outweigh the risks. And then any recent nuclear medicine study that may interfere based on the radiopharmaceutical. I want to point out that cardiac amyloidosis can also be scanned using 99M technetium, PYP, There's also a protocol for MDP/HMP. So it is still sometimes done using SPECT imaging. That's discussed in another course. Also, F18 flumetamol is fast-tracked FDA clinical trials at the time of this recording as an amyloid agent for detecting ATTR amyloidosis in cardiac. Flumetamol is one of the beta amyloid agents that's used for Alzheimer's imaging, and it does readily accumulate in places where there's amyloid plaque buildup. And so it does show a lot of potential for cardiac amyloidosis as well. The proposed protocol for that one is a 30-minute dynamic gated scan, and amyloid plaque in the myocardium is then quantified. And this is an example of cardiac amyloidosis accumulation. Next, we'll talk about cardiac sarcoidosis. So sarcoid is collections of granulomas in the tissue. This is something that is immune or autoimmune mediated. It is believed to be an autoimmune disease for generalized sarcoidosis. Cardiac sarcoidosis is a rare autoimmune disorder where the granulomas or clumps of immune cells will form in the heart tissue. This has a high risk for sudden death. It leads to heart failure, myocardial infarction, or cardiomyopathy. Symptoms of cardiac sarcoidosis can be life-threatening. Symptoms include chest pain, fainting, fatigue, irregular heartbeats, palpitations, shortness of breath, and swelling in the legs from fluid excess. Now, cardiac sarcoidosis affects 10 to 30% of patients with generalized sarcoidosis. It can be difficult to diagnose sarcoidosis as the clinical manifestations are often tachycardia or heart failure, but myocardial cells that are inflamed from sarcoidosis will metabolize glucose, and so that gives us an opportunity to diagnose it, where otherwise the best way to diagnose it would be through biopsy. So diagnosis is kind of complicated for cardiac sarcoidosis, but there are a couple procedures that assist. First of all, echocardiogram will show abnormalities in the heart muscle and valves. Doesn't necessarily show the presence of granulomas, but it will show the effect of sarcoidosis where it has abnormalities in the heart muscle and valves. An EKG will identify the correlating arrhythmias. So a lot of times tachycardia is one of those. Holter monitor is just a longer evaluation to identify those rhythm disturbances that can occur secondary to sarcoidosis. PET imaging is great for assessing the presence and extent of inflammation within the myocardium or within the heart. And then the cardiac MRI can also identify myocardial inflammation, but a tissue biopsy is the only way to really identify the presence of granulomas. Once a patient is diagnosed with cardiac sarcoidosis, the treatments include corticosteroids, immunosuppressive drugs, antiarrhythmic drugs, catheter ablation, and implantable cardioverter defibrillators. A lot of it is the corticosteroids and immunosuppressive drugs are meant to keep more granulomas from forming, but the antiarrhythmic, catheter ablation, the implanted defibrillator, those are all meant to help control the effects and the secondary effects that will occur from cardiac sarcoidosis as it affects the heart function. So indications of cardiac sarcoidosis imaging with PET are evaluation of suspected cardiac sarcoidosis in patients with at least two of the following: EKG evidence of a complete right bundle branch block or left bundle branch block, unexplained pathologic Q waves in two or more leads, echocardiogram evidence of regional wall motion defect, aneurysm, basal septal thinning, left ventricular ejection fraction that's less than 50%, Holter findings of a sustained and non-sustained VTAC, cardiac MRI findings suggestive of cardiac sarcoidosis, and unexplained palpitations or syncope. So they have to have at least two of those, or in evaluations of patients that are less than 60 years old with unexplained new onset conduction system disease, such as second or third degree AV heart blocks, or evaluations of patients with idiopathic. Remember, idiopathic is unknown origin. So evaluation of patients with new unknown onset of sustained VTEC not meeting the following criteria. Basically, when it has no other cause that can be found. So that third one there is patients with sustained VTAC, really where there's no origin or cause that they can figure out for it. And then lastly, evaluation of a patient with cardiac sarcoidosis following therapy. So in that case, the sarcoidosis is known, and we're just sort of evaluating the progression of it or restaging it. So there are no hard contraindications for this cardiac sarcoidosis with PET. Relative contraindications are pregnancy or breastfeeding, and then any recent interfering nuclear medicine study. In this image, you see coronal views of a patient with sarcoidosis. Patient was scanned for diagnostic purposes. In the first image, and sarcoidosis can be seen, particularly in the left atria and along that inferior lateral wall. And then in the second image, the patient is reevaluated, and you see much more advanced disease seen throughout the heart. And so you can even see it there in between the atria and the ventricle, across the anterior and inferior walls, and in the atria. Patients should follow a high-fat, low-carb diet the day before the test and then fast for 12 hours leading up to injection. If patients cannot follow the diet, then they should fast for at least 18 hours. Either way, water is permitted. Diabetic patients, the type 1 diabetics, should continue basal insulin but avoid fast-acting insulin if they're able to. Type 2 diabetics should avoid oral agents and non-insulin injections during fasting and then the morning of the test as well. It is important to get a detailed patient history for cardiac sarcoidosis imaging, and this should include a history of any sarcoidosis, cardiac or extracardiac, history of arrhythmias, specifically bundle branch blocks, tachycardia, or AV blocks, any symptoms that the patient may be experiencing, all of the medications and supplements that they take, results of any previous evaluations, and that includes echo, MRI, stress testing, anything like that, and then any previous cardiac history. Patients also receive a resting rubidium or ammonia study for comparison and then are given FDG. So in that way, this is very similar to the viability studies, except the actual imaging is a little bit different. So patients will get their rubidium resting or ammonia resting completed first, and then the FDG will be administered. Again, this has to be administered slowly over 1 to 2 minutes. Patient is then scanned 60 to 90 minutes later. They may be scanned for 10 or 30 minutes, somewhere around in there, just like a viability. Or they could get whole body imaging, just like an oncologic study protocol, and that would be from their vertex to their toes. You want to get their whole body because those granulomas, if it's systemic, can form anywhere. The whole body scan is preferred to detect any systemic disease, and there are a couple different variations to the standardized protocol. And it really, the variations has a lot to do with physician preference, but it should predominantly be led by the patient's history and what you're evaluating them for. If it is just cardiac only and there's no known systemic disease or evidence of it, then one variation would be to just do cardiac only scanning, just like a viability protocol. Otherwise, another protocol is partial body, where you're just essentially looking at the torso, or even chest, abdomen, and pelvis area, and to include the mediastinum and the lungs, in case that's a most common area that systemic sarcoidosis will be found, is in the chest, around the thymus, and in the lungs, or a whole body from vertex to toes. And that is done in the presence, either known or suspicion of systemic sarcoidosis. Another optional variation is to administer 10 micrograms per milliliter of unfractionated heparin, and this is given IV 30 minutes before, followed by another 5 international units per kilogram 15 minutes before the FDG. And the administration of heparin in this way will suppress the myocyte uptake of the glucose, or the patient could receive 50 international units per kilogram 15 minutes before FDG administration. So the two options there are 30 minutes before, they'll get 10 micrograms plus another 5 international units per kilogram 15 minutes later. And then 15 minutes after that, they'll get the FDG injection, or skip all of that altogether and just give them a higher dose of 50 international units per kilogram 15 minutes before the FDJ administration. This is the protocol for cardiac sarcoidosis. You'll know that it's very similar to the FDG. Patient will follow that high fat, low carb meal for about 12 hours. They'll get their resting MPI study. Blood glucose will be obtained. Heparin will be administered at that point if it's part of the protocol. And then the FDG is administered. And then about an hour later, they get their attenuation correction CT. They'll get their PET study, whole body, if they're getting whole body, and then followed by the cardiac only scan. And if they're not getting the whole body, then you would just do the CT followed by the cardiac FDG scan. So that whole protocol, if they're doing the whole body imaging and everything with it, will take about 3 hours. If they're not doing the whole body scan with it, then it will only take about 2 to 2.5 hours. And this is an example of a patient with sarcoidosis. And you can see any of the areas that are outside of the normal FDG biodistribution. You see that there is some accumulating in the heart. So this patient does have a little bit of cardiac sarcoidosis, but also you see that there are areas in the mediastinum, probably in the lungs, of abnormal uptake. There's also some here in the abdomen, and then you see some more in the pelvis. So this person has a little bit more extensive sarcoidosis. Typically, the protocol will be the MPI protocol, where the resting is displayed as a normal MPI resting, and then the sarcoidosis images will appear in place of the stress, very similar to the way it is on a viability study. It'll be processed with iterative reconstruction using OSEM and attenuation correction, preferably with a CT scan. Align the resting and sarcoidosis slices, like I said, just similar to the way they are in a stress test, and quantitative data may be displayed. Images can be visually graded for the whole left ventricle using a subjunctive scale corresponding to radiopharmaceutical uptake, and it uses a scale such as none, diffuse, or focal uptake. And then a semi-quantitative method is to sum the number of segments in a 17-segment model that are visually positive for FDG. And quantitative methods are used to measure the standard uptake value of the cardiac volume of interest obtained from the fused FDG CT images and to obtain the automatic 17-segment scoring of the rubidium perfusion by comparison to a normal database. These images show the classification of normal versus abnormal for sarcoidosis imaging. So in the very top row, this is a normal one. There is normal perfusion with no FDG uptake, meaning no inflammation within the heart. For the second row, it's mild or early disease. You see another one of those mismatch patterns, perfusion with no or a mild defect. And then on the metabolism images, the FDG uptake will show up in the area of that defect. There's showing that there's some inflammation there. Moderate to progressive disease has a focal mismatch pattern, FDG uptake in the area of the defect that's seen, and then severe or fibrous disease will show that there's a severe defect on the perfusion and no or minimal uptake on the FDG. This image is a little bit fuzzy with the text, but you can see in the first three rows, there's normal perfusion. This one was done with nitrogen 13 ammonia. So there's normal perfusion on the first three. In the top row, there's no FDG uptake. That's a normal study. In the second row, you have some focal FDG uptake. This is non-specific inflammation or accumulation. And then in the third row, there's normal perfusion with diffuse FDG uptake. And this is poor diet prep, so this would be considered a non-diagnostic exam. The myocardium is taking up too much glucose because the patient was not properly prepped with the right diet. And then the fourth row has a mild perfusion defect, and the FDG uptake is focal in that area that is kind of matching or mismatching, I guess, where that uptake is. It's kind of showing up as focal uptake in the area of the defect. That's early sarcoidosis. In the fifth row there, you have severe perfusion defect that's seen on the MPI resting study with corresponding FDG uptake in the areas of the defect. And this is moderate to progressive disease. In the bottom row, we see severe perfusion defect and no FDG uptake, and this is fibrous sarcoid or other etiologies where there's scar tissue now in the heart. Thank you for watching this. I hope you enjoyed this video.